You had Belzer and Hannum did the same thing. They took people that had group function occlusion. So when they went to the right, all the teeth on the right touched. They built up the cuspids with composite. Now you had a canine guided occlusion. And their conclusions were when you had a naturally acquired group function and you temporarily and artificially changed it to a dominant canine guidance, you saw a significant reduction in elevator muscle activity. And then finally, Arturo Mans did the same thing, but he used occlusal appliances. So he used occlusal appliances that were flat plane appliances that were group function, and then he used appliances that had ramps in the front so they had canine guidance. And he had the same thing, electrodes on master and temporalis, and every appliance that had the canine guidance had less muscle activity than the flat appliances. And so you look at those three kind of major works from the 1980s and you go, well, of course, if you create canine guidance and you do all those things that I was taught, muscles behave. No problems. And they're problems we really didn't think about for a long time. And the biggest flaw is that this is a temporary and artificial change. None of these people were followed long term. In other words, does the muscle changes you see in this relationship when you build a cuspid up during an appointment, does that muscle activity change is it still there 3 months later? Or do the muscles go back to doing what they used to do? So there was no long-term follow-up, basically. Now, the challenge is when you go in the literature to try and really look for long-term follow-up, there's not a lot of articles. So this is an interesting one from 2011, looking at the impact of changing vertical dimension on muscle activity. And the reason it's an interesting study is they actually used occlusal appliances to open the bite, but before they did it, they measured resting muscle activity and clenching activity. And then they basically came back, put the appliance in, measured resting and clenching activity, and then did it again at 1 week, 1 month, and 3 months. And these people wore the appliances the whole time. Following the appliance insertion, there was a reduction in muscle activity for the first week and the first month. At 3 months, the muscle activity was all the way back where it was in the beginning. And visually, it looks like this. Here's the muscles that the electrodes were placed on. Here's the patient clenching before the appliance was inserted. Here's clenching on the appliance immediately after insertion. There's almost no change whatsoever in muscle activity. Here's the person wearing the appliance for a week and the muscle activity starting to go down. Here's the person wearing the appliance for a month, and now the muscle activity is definitely down. But now they continue to wear the appliance, and at 3 months, it's all the way back and actually almost above where it started. So the challenge we have in occlusion is we developed a lot of our beliefs around the fact that we thought we could control muscles, that if we did certain things, that patient's muscles would behave the way we want them to, but we didn't have any long-term follow-up to prove that. And what it looks like now is that, in fact, there's this adaptation that occurs, and maybe muscles are going to go to where muscles are going to go in that patient. Now, in terms of a really unique study, in 2008, Rodolfo Morales was part of Arturo Mans' team that worked with occlusal appliances in the 80s. He had a really unique idea. He said, well, if really the occlusion makes a difference, let's find 15 people that have naturally occurring group canine guidance, 15 with naturally occurring group function. Let's bring them in, have them grind out to the left, clench end to end to the left, grind back to the center, and let's see if, in fact, there's any difference in the muscle activity levels between the people that have canine guidance and group function. In other words, instead of changing it during an appointment and seeing what muscles do, let's bring in people who are actually living with these different occlusal schemes and see what muscles do. And just grinding out to the left, no difference. Clenching edge to edge, no difference. Grinding back in, no difference. In other words, for the majority of the people that they evaluated, the muscle activity levels between the people with canine guidance or group function, they were the same. And so it starts to make you realize that occlusion's not, our theory has been that if we could shut muscles down, then our teeth survive. And what the research tends to say to me today is we may not be able to shut muscles down. So how do we make our teeth survive? If the patient's still going to do what they're going to do, how are you going to manage that? So for myself, I believe that altering occlusions has an impact on short-term muscle activity for sure. That's well documented. But whether what we do to the occlusion actually reduces patients' muscle activity levels over a long term, I'm not convinced about that at all. So what I hear people say is, well, if the occlusion doesn't control muscles, then occlusion doesn't really matter. I should just throw away my articulator and equilibration and everything else. And I look at it completely differently. To me, I think the occlusion matters more. Because if you can't control the muscles, then what you have to do is design an occlusion that survives the muscles. And so my approach to occlusion today is very different than what it was 40 years ago, 30 years ago, in that I'm not convinced my changes are going to change what the patient does. Instead, I'm looking at my occlusion and saying, how do I develop occlusions that will live given what the patient does? So a lot of what we were taught originally came around from occlusal interferences. So I want to just take a moment to talk about them as to are interferences really a problem or not. And I'm going to suggest to you they are. They're just not the problem we thought they were. We thought interferences triggered bruxism. We thought interferences made people clench and grind. That doesn't seem to be true. Interferences do bad things. And so if we really look at it, a lot of us were taught that if you had an interference when your condyle was seated, it would make the patient have this pattern of grinding back and forth, fulcruming off that interference. So if we take a look for literature relating to interferences and bruxism, interferences and occlusion, you have to be really careful when you read dental literature. So this is a 2013 paper that specifically looks at, is there a relationship between bruxism and premature occlusal contacts? So they took 60 people, 30 of them were diagnosed as bruxers. They analyzed their occlusion both in a seated condylar position, what we call centric relation, and also in lateral movements to see if they had interferences in the posterior. The results showed that there was a significant relationship between bruxism and lateral interferences, but there was no relationship between bruxism and interferences in central relation. In other words, that didn't seem to be related to whether the patient bruxed or not. But their conclusion is really what you have to look at carefully. Their conclusion said, according to the results of this study, there is a relationship between non-working interferences and bruxism. That sounds like the non-working interference is causing the patient to brux. But I would look at it again completely different. I would say, in fact, if a patient bruxes, what happens is they wear down their anterior teeth. And as they wear down their anterior teeth, what do they end up picking up? Posterior interferences, lateral interferences. So there may be a relationship between lateral interferences and bruxism, but I don't believe it's a causative relationship. I would suggest, in fact, that bruxism ends up with a patient having more lateral interferences because they wear down their anterior teeth and lose their anterior guidance. Now, if we look at a systematic review of a large number of papers on occlusal interferences, you can really group occlusal interferences into two camps. Those that are high restorations, in other words, they interfere with the intercuspal position, and those that contact when the mandible's moving. And so in this systematic review, this is where you learn that, yes, interferences are problems. Patients that have high restorations, in fact, can end up with mobile teeth, sensitive teeth, sometimes disrupted jaw function, sometimes jaw muscle pain and clicking, all from the placement of a high restoration. Interestingly enough, lateral interferences don't tend to do much to muscles, and they don't tend to do much to teeth, but they do have a risk of breaking teeth or making teeth mobile. So when we talk about interferences and occlusion, you have to separate out the concept of bruxism from the interferences. What appears clear from the literature is that interferences don't trigger the bruxism, which was what I was taught they did. Instead, they're negative because of their impact on teeth, the periodontium, potentially muscles, etc. So what does that leave us with bruxism? If interferences aren't related to triggering bruxism, what does cause bruxism? Well, it depends what years you look. If you went back to 2008 in Montreal, there's a really wonderful research group that Gilles Levine has been part of for 30-some years. And they've been studying bruxism, sleep, airway for decades. And in 2008, they wrote a paper for dentists, for clinicians, around this whole issue of bruxism, what's the physiology and pathology of it. What they basically said was awake bruxism is defined as awareness of jaw clenching during the day. Prevalence of awake clenching and grinding is 20% in adults. It actually starts lower than that, but by the time you're 60, about 1 in 5 adults clenches and grinds during the day. The physiology and pathology of daytime bruxism is unknown, but stress seems to be a risk factor for it. And nocturnal bruxism, the average population has an incidence of around 8%. We know young people have a much higher percentage of frequency of bruxism. As you age, by the time you're 60, only about 3% of 60-year-olds brux at night. 1 in 5 bruxes during the day. What they said in their 2008 paper is that research suggests sleep bruxism is secondary to sleep-related microarousals, and they tend to be repeated 8 to 14 times an hour. And what's called an RMMA, rhythmic masticatory muscle activity, that's the actual clenching and grinding from the muscles, has a relationship to this microarousal. So it looks something like this. Something triggers the sympathetic nervous system. In 2008, what they said that something was apnea. You then get a heart rate increase, you get brain activity increase, you get suprahyoid muscles starting to contract, and now those elevator muscles start to go through contraction, and a certain percentage of people then brux. So that was what bruxism looked like in 2008 to Levine's group. The microarousal, as I said, the primary one was airway-related oxygen desaturations. Now, what that meant was, if you listen to a lot of speakers in 2008 talk about bruxism, what they would tell you is if your patient bruxes, send them for a sleep study. And so a lot of us really got on the bandwagon of, well, there's your trigger. If we have a patient that bruxes and it's not occlusal interferences, let's get them over for a sleep study. Here's 2016, same exact group, same researchers. Look at the title of the article. There's a weak association between sleep bruxism and obstructive sleep apnea. Wait a minute. I thought we just got done saying that there was a relationship. Now it says there's a weak relationship. And in fact, this is the way dental research works. What happens is we get an idea that seems to be correct, and then we dive deeper into it, and we learn that it's not as correct because it doesn't fit the bell curve. The bell curve was those people in the middle. Now, all of a sudden, when they start looking at more and more people, they discover only about half the patients who brux have apnea that's concomitant with the bruxism. And so there's something else happening. And their conclusion in 2016 was sleep bruxism and obstructive sleep apnea are not strongly associated. And they believe that, in fact, there may be some other issues related to what's causing the bruxism. And I'm not about to tell you that I believe I know what causes bruxism. What I know is it's very confusing and it's not nearly as clean cut as we would like, which means to me, you have to develop the occlusion to survive it. Okay? And then finally, in another paper, the same exact research group again discovered that in fact very, very small desaturations of oxygen, very small 1 or 2% desaturations, seem to be related to bruxism in some people. So how do we make sense of all of this? Well, it appears that the etiology of bruxism is clearly multifactorial. It also appears that occlusal interferences definitely aren't related to it. In some patients, it's preceded by apnea. In other patients, it precedes, the bruxism precedes any desaturation. In still others, there is no desaturation. And in some patients, stress plays a role in it. And what we do know is if you do have a person who apnea plays a role in their bruxism, then yeah, those people, if you correct their airway, they do end up with a significant reduction in bruxism. But that's not everybody that bruxes. So again, for me, what it comes down to is this. If we believe the patient's going to continue doing what they're doing, then we need to try and develop an occlusion that will survive it. And that's all about force distribution. So what I want to walk you through is what does that occlusion look like? So I've kind of tried to give you a background on this is where we came from. This is where we are. I wish we were in a different place. I wish we had a better understanding, but I don't really think we do yet. And so as a clinician, you still have to treat patients. And so the question becomes, how do you treat patients so that in fact they survive this process? So the way I like to think about occlusion is occlusion as an entity is this big term. There's so many different things that go on with it. So I like to think about occlusion as 4 different occlusions. There's your bite, the intercuspal position. There's your guidance, how you get from your intercuspal position out edge to edge, out laterally. So we'll call that pathways of guidance. There's your end-to-end and crossover occlusions. So when you're out on your front teeth or you're going left or you're going right, what's the bite like when you finally reach the edge? The end, your retruded occlusion. In other words, when your condyle seats, what does your occlusion look like? So we'll start with intercuspal position. We'll call it MIP, maximum intercuspal position, which is really your bite. And what we want is pretty simple. We want it so when the patient closes, all their teeth hit evenly. The debates in occlusion would be, well, do you make their bite fit with the condyle seated? Do you use the bite they have? And if we're honest, the majority of dentistry done in the world is what's called conformative dentistry. It's just done using what the patient has, and it works really quite well most of the time. Most of the time when you're seating a restoration or placing an implant and restoring it or doing any of those things, you simply say to the patient, bite. You take articulating ribbon, you see if your restoration's high. If it's high, you grind it until the adjacent teeth hit, and then you have them grind left and right and forward to make sure that you don't have any eccentric interferences, and you're fine. But there are times that we're going to want to change the intercuspal position, especially if you happen to be restoring an entire arch or you're doing a full arch of implants. Sometimes even you might want to equilibrate the patient's teeth because the occlusion is doing some things that you don't like and you want to alter it. So when we think about what determines the intercuspal position, by far and away, as I said, the most common thing dentists use is they use the existing teeth, and it really works quite well in the majority of patients. If you're not going to use the existing teeth, then typically, historically, we use the jaw joints and we use a seated condylar position, which has been classically called centric relation. If you look at nathology or Pankey Dawson or bioaesthetics, they all teach some form of seated condylar position. The neuromuscular folks use muscles and the myomonitor to determine where to put the mandible in order to create an MIP. There are some patients where you actually have to use comfort. If some joint issues and the joint is uncomfortable in a seated position, you have to build the occlusion forward to get them comfortable. And in some patients, airway determines where the mandible ends up being positioned, so that in fact you open the airway. The majority of the folks, however, we're going to use probably the first two. If the patient, we're not restoring a lot of teeth, and if they're asymptomatic, we're just going to use their existing teeth. And if I am going to change it, and as long as their joints, in fact, are structurally fine, I'm probably going to use the joints to determine the new MIP. So the concept of centric relation versus intercuspal position, and you'll hear me say seated condylar, fully seated condylar position quite often. The trouble I have with the term centric relation is it tends to carry a lot of baggage because most of us were taught it, but depending on what school you went to and when you went there, the definitions of centric relation are all over the map. Is it the rearmost position, the uppermost position? The position we want is the position all by itself, which is up and against the anterior wall of the fossa. You don't need to manipulate a patient to get that. You can, but you don't need to. So what I want to do is I want to look at this whole concept of, well, so do humans have centric relation equal to their intercuspal position as a natural phenomenon? In other words, how many people have what I was taught was ideal? So this is a study on pre-ortho patients, 107 of them. Of the 107 patients, they evaluated the seated condylar position using a deprogrammer and then had the patient close to see if there was a shift. And they had one person out of 107 that didn't have a shift. And I could show you 10 other studies that show the same thing. In naturally occurring dentitions, most humans, their intercuspal position does not match their seated condylar position. Now, what I want you to pay attention to is this one. Out of those 107 patients, 20 had a condylar shift of greater than 2 millimeters between those two positions. In other words, from the intercuspal position, when the condyle went back and up into its seated position, the condyle moved more than 2 millimeters. That's a lot. Here's the good news. Most people have 5 to 7/10 of a millimeter, really quite small, which is really good news, and you're going to see that in just a second. So what I want you to see out of this one is the two things I want you to get out of the study. One is that in general, a naturally occurring dentition does not have the condyle in a fully seated position match its intercuspal position. And the other is that, in fact, about 1 in 5 people has a pretty significant shift between the two positions. And in this study, there was no statistical difference in the shift between a class 1 versus a class 2 occlusion. Now, if we build people to CR, what I want to just address that for a second. If we actually decide to put a patient into a seated condylar position and we restore their teeth there or we equilibrate them there, does it stay forever? So this is one of the best studies I know of on that topic. Frank Salenza, senior, excellent prosthodontist from New York, had 32 patients he did reconstructions on. He deprogrammed all of them using a Lucia jig as an anterior deprogrammer to find a seated condylar position. And he restored those 32 patients and then followed them from 2 to 12 years. Every year, he would bring them back and he would check to see if they had developed a shift. Because when he finished the reconstructions, there wasn't any shift. When the condyle was seated and they closed, their bite fit perfectly. On recall, when he brought them in and tried to just simply manipulate them or ask them to bite, all of their bites were fine. When he put them on a Lucia jig for 5 minutes to deprogram them and then took the Lucia jig out, 30 of the 32 patients had a shift, which is not surprising at all because jaw joints change, discs change. It's a fairly adaptable system. Now, that doesn't mean there's anything wrong with the reconstructions or they needed to be treated or equilibrated. It's simply what happens over time to the body as it ages. What's important to realize, though, is the patients were all doing fine. And so when we use a seated condylar position, the typical reason we do it is it's our home base. It gives us a repeatable position to build MIP at that time in the patient's life. If it changes over the next 10 years, so be it. I don't go in and chase shifts or look at it. I don't even look at it on recall typically. And what came from Salenza's paper is really a quote that I think is real appropriate, is the precision of the occlusion is probably more important than the position of the occlusion. But the challenge is we need a repeatable position. We need to be able to have the patient close and know that if we make bite records and send it to a lab, that when we get it back on and we put it back in their mouth, they're going to close in the same place again. That's the reason repeatability is important. So let's talk about some really simple dentistry that can end up making some significant changes. So are there times a single change to one tooth can destabilize the patient's intercuspal position? And so this is a patient that I'll walk you through. He's a dentist. He wants some improved aesthetics. So we're going to do some crown lengthening to clean up some tissue levels. We're going to do some veneers. But he happens to have cracked molars on the upper right. And so we're going to have to restore those 2 cracked molars. He also had a cracked molar on the lower right as well that just finished having endo. And when you ask him to bite, his bite is fine. Now, let's talk a little bit about intercuspal position and muscles. So the elevator muscles all want to lift the condyle up and forward. In other words, if we didn't have anything in the way, when those muscles contract, condyle would go up and forward into a seated position. The medial pterygoid wants to do the same thing. What keeps the condyle from being in that position are posterior teeth and the lateral pterygoid muscle. The lateral pterygoid pulls the condyle down and forward. The lateral pterygoid is programmed by the posterior teeth. In other words, the lateral pterygoid holds the mandible, so when you bite, your back teeth fit. What a deprogrammer does is an anterior deprogrammer separates posterior teeth so that, in fact, the lateral pterygoid can relax because it doesn't need to hold the mandible forward. And when the lateral pterygoid relaxes, the elevator muscles automatically seat the condyle. The deprogrammer doesn't seat the condyle. The elevator muscles seat the condyle. So what that means is, if you had this situation where you have this shift back and forth, is the lateral pterygoid learns that if it was relaxed, your teeth don't fit. You would only be hitting your second molar. So the pterygoid stays cracked so that you stay in your intercuspal position. But now there's a problem. What happens is, as that condyle seats, you're only hitting the molars in the back. And if you happen to prep one of those second molars, but you prepped it when the bite was like that in the intercuspal position, but now after you prepped it, there's no interference anymore, and the condyle now seats, you lose your interocclusal clearance. You lose your space that you prepped for your restoration from condylar seating in those people that have those greater than 2 millimeter shifts. So before I treated him, I mounted his models using a deprogrammer. So these models are mounted with his condyle seated. And what are the only teeth that touch? When he goes into a retruded position, which is where his condyles go all by themselves when his pterygoids are relaxed, the only teeth that hit are the cracked molars. And he has a really significant shift. He has to slide forward several millimeters. Now, I talked to him about wanting to change his bite and equilibrate everything prior to doing the veneers, and he said, you know, I'm perfectly comfortable. I mean, the cracked teeth, you're going to have to restore them anyway. I don't want you to alter my bite. And so I prepped the veneers, I prepped the molars for occlusal coverage, and a few weeks after I put provisionals in, he called me and said, hey, I got to come see you. He'd broken the provisional on the second molar, and he'd worn all the way through the provisional on the first molar to the prep. Look at the rest of the provisionals. They're fine. What happened is, as the condyle, when I prepped those teeth and took away the interferences, over the next few weeks, his lateral pterygoids relaxed, and as they relaxed, the only teeth he was touching was those 2 molars. Now, if I ask him to bite forward, it'll appear as though he actually has some clearance. And you might say to me, well, why don't you just have the lab build the restoration here? Let's make the bite record with him forward because you've got space. Think about that. You build somebody forward, and now when their condyles go back, the only thing they're going to be touching is your restoration. You don't want your restoration to be the only thing contacting his entire occlusion. So when these patients who have these larger shifts, this is the patient who, as long as his jaw joints are structurally stable and comfortable, I am going to redo his restorations. I'm going to redo him in a seated condylar position. Now, when I asked him to bite, if I took that provisional out and I just said bite to him, look what happened to the clearance. Totally disappears. Why? Because his condyle seated. I didn't seat it, his muscles seated it. All I did was get rid of the molar interferences that had been teaching his lateral pterygoid to keep him forward. But remember, he had cracked both these teeth. So if you wanted a good picture of it, it looks like this. Condyle seats, that's what happens. You prep the teeth in MIP, you got plenty of clearance between your preps. Condyle seats after you do the preps, and your clearance. Okay, so that's the challenge of MIP. What did I do? I seated the condyles, I re-prepped the whole case, re-prepped these teeth, prepped that lower one that had been cracked as well. And now when the condyles are seated, his MIP, everything touches evenly, his anterior teeth touch, there's no shift. Here was my provisionals. I left him in for like 3 months. There they were, the first set after a few weeks. And he's been treated for probably 15 years with all bonded porcelain. He's done great. So that's the challenge of MIP. Now, the usual question I get is, so how can I predict this? How can I predict who that person is? And the answer is you actually can do it by measuring the shift pre-treatment. So if you learn to use a Lucia jig, or I prefer a leaf gauge will help you seat the condyle and then dial it down until the posterior teeth touch with the condyle seated. And now you'll measure the overjet between the upper central and the overjet when they come seated and the patient's touching the posterior interference. And now ask them to bite into their MIP and remeasure the overjet. And if that anterior shift is 2.5, 3 millimeters plus, that is a really high-risk patient in terms of you losing clearance and you ending up with a patient whose bite changes following the restoration of a single tooth. Okay? So simple rule, the larger the anterior shift, the more at risk you are for losing the intercostal position. Now, what's the other way you can see this coming? Look at the teeth. Look at the lower right second molar. It's worn clear into dentin. Okay? Look at her teeth. They're beautiful. Nowhere anyplace except the second molars. What is that telling you? She's a patient who has a big shift. When she drops back, the only teeth in her mouth she's touching are those second molars. The upper is cracked, the lower is worn into dentin. This is a patient with her condyles seated, and you would actually be able, on the mounted models, to prep these teeth and figure out how much clearance you're going to lose and what's going to happen to the rest of her bite. All right. The other two positions, pathways. When we think about pathways, typically in protrusive, we put our protrusive guidance on centrals, and laterally we put it on the canines. But in some cases, I want to just touch on when group function using the canines and the premolars can be beneficial. And then I want to talk a little bit about the concept of a restricted pathway, a restricted envelope of function. So let's do the canine guidance versus group function for a second. So canine guidance really came about in 1961. D'Amico was the person that really popularized the concept. Does canine guidance occur in the natural dentition? Weinberg did a study on that in 1964. 81% of the humans he studied had group function. Only 5% had canine guidance. Now, you study 25 years of age, you get a totally different result. Under 25 years of age, huge amount of percentage of the people have canine guidance. So what you learn is that as people age, the canines wear, and they wear into group function, and people do just fine. Now, why do we want anterior guidance? Why do we like canine guidance? Because it separates the posterior teeth, which protects them from wear and fracture. So we use the anterior teeth as a tool to keep the forces off the posterior teeth. Molars receive 7 to 8 times the force of anterior teeth. And so the weak link of using canine guidance is that all of the force is concentrated on very few teeth. That's the weakness of using it. And so the rationale for group function is it's a way of distributing loads. So if we have somebody who puts excessively heavy loads on their teeth, by having multiple teeth touch when the patient's moving left, we're spreading the load out over multiple teeth. And what's the weak link of group function? One is it's harder to do, and the other was potentially, if we believe what we used to believe, is group function has more muscle activity than canine guidance, but I'm not convinced that's true today. So group function for me is you use the canine and the two premolars. Canine guidance is you only use the canine. When would I consider using group function? Fairly routinely, when I have canine pontics and an FPD. Now, anytime you have an FPD, and I know this looks like it should be an implant case because it should be an implant case, except the patient won't do the implants. So we're going to end up doing an FPD. And when you have an FPD, the middle of the pontic span is always the longest lever arm. You always typically want your guidance as far forward on an FPD as you can. In this case, I can't use the central incisor. This case is splinted, and so the guidance is the lateral, the canine, and the premolar, and it's very shallow guidance so that it's relatively flat. Here's the same case 17 years later. Why has she done so well? Because she doesn't grow. That's the only reason she's done so well. But group function, if you will. What about a canine implant? No buccal plate, implant goes in. Dave Matthews, my periodontist, did the grafting, membrane. Here it is at uncovery, great result. Now, do we put the guidance on the cuspid, or do we use the adjacent teeth? This is an old external hex implant. External hex implants are notorious for screws loosening. Modern implant, I would use like a Straumann bone level fixture. I would use the canine guidance, wouldn't bother me. On this one, what did I do? I put the guidance on the premolar. Why? Because I don't want to have to deal with loose screws all the time. Here it is 22 years later. And 22 years later, she decided that she wanted to bleach her teeth, and she knew the crown wasn't going to match. She also noticed that her teeth had erupted a little bit in those 22 years relative to the cuspid. And so what's interesting, though, is if you look, there's the premolar that's been providing guidance for 22 years, and there's no wear of it at all. And on the other side, the canine's been providing guidance. Both sides work fine. Premolars do just fine providing guidance. And here she was after bleaching and redoing the crown. When else would I for sure do canine guidance or group function? Structurally weak cuspids. You don't want to use this canine as your tooth to manage the guidance on. This patient was treated by one of our grad students. He did a real classic nathologic occlusal scheme, canine guidance. That post-core crown came off in 7 months. I'm actually shocked it lasted that long. Mobile canines, look at the amount of bone left around that root. If you're going to keep that tooth and use that tooth, don't put canine guidance on that tooth. Here's that same case 20 years post-treatment. Group function, canine, both premolars. And bruxers. This patient loves grinding left and right. You can take a look at the wear facets you see on her canines. So here I have put in the impressions, put in provisionals, pulled retraction cord. That's why the tissue's so angry. And I'm finalizing the occlusion. And the way I do it is I start with canine guidance, and I wait to see what the patient does if they have any problems with knocking canines loose. In an edge-to-edge occlusion, which is the third part of the occlusion that what we wanted to talk about, in protrusive, when we're out edge-to-edge, we want the broadest, flattest contacts we can in people with brux, so it spreads the load across. So there's what I want end-to-end protrusively. When she goes to the right and she reaches an end-to-end canine position, I want the centrals touching. So she comes out on the cuspids, and as soon as she gets all the way out edge-to-edge canine, I want the centrals now touching, so it's a smooth slide beyond that. If we were doing group function, we would have also had the two premolars touching. So as she came out, she would have been on the premolars and the cuspid. In this case, I'm using canine guidance to get her out to the edge-to-edge position. Then she could go to this end-to-end relationship. Now we go the other direction, and same thing. She's on the canine only on her way out. And then once she's end to end, she hits the central and the canine, so she can slide smoothly in and out from there. If we were doing group function, we would have had it so she would also be picking up the premolars. How did she do? Not well. Canine came off the right side within 3 days, and the left side as well. I bonded them back on. She knocked them off within days. I bonded them back on. She knocked them off. After 3 times of bonding them back on, I reduced the length of the canine, shallowed them out, added a little bit to the buccal cusp of her premolars, and created canine guidance. So now, what canine, or group function, excuse me, if you would have looked, this is what canine guidance would have looked like, is she would only be touching the cuspid on her way to the right. But instead, you'll notice as she goes right, she picks up the buccal cusp of the premolars as well. Same thing on the left. And here she is 10 years post-treatment. And what's interesting, if you look at her pre-treatment, look at the lower cuspid and premolars. She's now she's treated, I think, 20 years this year. You look at her lowers at 10 years, really not a whole lot of change. And those teeth, the 2 premolars and the cuspids, they provide the guidance to the right. And the same thing. Here's the pre and post-treatment, very little change in the lower posteriors. And if you take a look, that's what she looks like 10 years post-treatment. As I said, I don't have a current photo of her. She doesn't live in the state of Washington anymore. And so I haven't been able to get a photo of her for a while. Now, you saw the edge-to-edge relationship we try to create. Let's talk about this concept of a restricted pathway. So when we talk about the pathways of guidance, what we're really talking about is overbite, overjet, and inclination of the maxillary teeth. Think of the lower incisor as a stylus and the maxillary anterior tooth as the pathway. The more upright the maxillary tooth is, the more locked in the patient is. The more proclined the upper tooth is, the more freedom the patient has. What we want is this relationship with, on an average, let's call it 3 millimeters of overbite and a nice smooth amount of freedom. When you see people that have upright centrals, deep overbites, they tend to have very tight occlusions. A lot of people do fine with that. But there are people that won't tolerate it. And if they don't tolerate it, what they do is they fight it. And they'll get mobile teeth, they'll get teeth migrating and opening up diastemas. They get wear on the palatal of the upper anteriors, wear on the facial of lower anteriors. And as those teeth wear, the upper comes down, the lower goes up. And the challenge is the bite gets tighter. As the wear occurs, the bite gets tighter and tighter. And so these cases are really difficult to treat without ortho. So what you want to do is you want the orthodontist to take the upper central and correct the initial problem. It has to be proclined. And then intruded, ideally intrude the lowers, and now you have room to come in and restore the case. So you take this tooth, this is what you want. Your problem is you can't take the tooth on the left and prep it and try and make it look like the right. In other words, you can't correct tooth inclination with a burr because he's already worn the palatal out of the tooth. So these cases, if you want to treat them in opening vertical dimension, seems like it would be a solution. The trouble is these teeth are over-erupted. The lower incisors are often over-erupted, the uppers erupted down. You open vertical and you have teeth that are not in the correct position in the face. So these cases, if you tried to prep it to fix it, you'd end up with a prep like that. You'd have no tooth structure. So just to show you an example, this is a young female. We're catching it relatively early before it advances to a really severe state. But some of the classic things you see in patients with pathway wear. A lot of tooth display at rest. Why? Because the teeth have erupted down. You got a step in the occlusal plane because the teeth have erupted down. And why have they erupted? Because there's palatal wear on the anteriors and facial wear on the lower incisors. Take a look. There's the deep overbite. And look at the lower incisors. You see the angular wear. Angular wear facets, not flat wear facets. The flat wear facets are people with end-on only wear. They do really well when you follow those occlusal schemes we talked about earlier. So there's the problem. Notches all the way up at the palate, angular wear on lower incisors. How do you manage these patients? You got to give them freedom. They need overjet. You don't want to tighten their bite at all. They need overjet. So the ortho is going to procline the upper incisors and intrude them. We're going to build up the lower incisors with composite, and the orthodontist is going to intrude those as well. So now you go from 100% overbite to nice level occlusal planes. Notice on the right how nice the overbite-overjet relationship is turning out. So you have level maxillary occlusal plane, level mandibular occlusal plane. The mandibular incisors were restored with composite. The maxillary incisors actually have old veneers on them. We're going to take those off. And normally, because there's so much wear on the palate, you would do full crowns. But instead, in this patient, because we're trying to be conservative because she's really young, we're going to just redo these veneers and then do direct composite on the palate so we don't have to prep any more of the tooth away. So there are the provisional veneers in place, and you can see the lingual of the teeth is still dentin. Here's now the final veneers in place and the composite, direct composite being done on the palatal because the occlusion's not there anymore anyway. The occlusion's way up, about 2 or 3 millimeters of overbite. And so that's your pathway wear. And then, as I said, the biggest key is once you do edge to edge, it's when you're in protrusive position, you want broad flat contacts. As you go left and right, when the canine reaches an end-to-end position, you want the centrals touching. And with that, I think it's time to do some Q&A.
Excellent. We have some fun ones here. I've been trying to answer some as I could, but this is a fun one. And there were 5 studies in the 50s with telemetry that showed that CR changes down and forward. And that was after careful equilibration to from MIP to CR. So they took out the shift. And the conclusion was that CR is not a stable position, but will change and adapt. That's more of a statement, but when I saw it, I knew you'd want to comment on it because.
Yeah, and I think I would agree with the fact that I think CR does change and adapt. It doesn't invalidate using it when we need a repeatable position to build somebody's occlusion. In other words, if you look at the literally millions of patients that have been treated using CR, I would also say, if you're talking about the 50s, you want to know what position were they considering CR. Because in the 70s, when I was trained, the position I was taught was retruded. You pushed the patient back. And for sure, those people are going to come forward. They are. So the position we use today is a totally different position than that. We're trying to get the condyle simply up and forward. We're not trying to get it back. But even as I showed you from Salenza's study, even if you use a deprogrammer, it does change and adapt over time. And that's it. Face it, most humans, 99% of humans, don't have CR and MIP match it. But when we treat a full arch, we need a repeatable position to make bite records. And it does become a very repeatable position that works for us. So that's how I would respond to that.
Okay. At previous SPEAR seminars, I've heard that people tend to perform parafunctional habits during the day more than at night. Did I hear correctly in today's lecture that that may not be the case?
No, that actually is the case. If you look, 1 in 5 adults at age 60 is grinding and clenching during the day. At age 60, only 3% of adults are, in fact, grinding at night. The studies we also have show us that, in fact, daytime, the forces that you clench and grind with during the day are actually almost typically double what the forces are when you're sleeping at night and grinding. So daytime grinding is an issue. And an interesting way to think about it is, think about in your own practice, how many patients you have that fracture teeth. And how many of those patients that fracture teeth tell you they woke up in the middle of the night with a broken tooth in their mouth? as opposed to how many people tell you that I was just eating a soft piece of bread and it broke. I was eating a bagel and it broke. It broke during the day. So yeah, daytime grinding and clenching is an issue.
Okay. What is the best method of positioning a patient into CR?
So as I said, bilateral manipulation works, but it's something that a lot of people aren't very confident with. So what we teach is we teach a Lucia jig and we teach leaf gauge. Both have been around since the 1960s. I think the Lucia jig was invented by Vic Lucia in 1964. The leaf gauge was invented by J. Hart Long in 1968. I've used both of those techniques. I learned the leaf gauge in 79 in grad school. And the concept is really simple. Either one of them separates the posterior teeth. And when the posterior teeth are separated, what will happen is the elevator muscles will seep the condyles for you. So you don't have to touch the patient. So we use either of those two techniques. The reason I like the leaf gauge is that it's adjustable in height. It's literally like little leaves. And you take the leaves out so you can get the patient's condyles seated, but then you can start dialing the leaves down until you find out what the actual first point of contact is, measure the overjet, take the leaf gauge out, ask the patient to bite into MIP, measure the overjet. That's how you can start judging your risk of that shift we talked about.
Interesting one with the airway things. If you restore the patient in CR, could you cause a breathing issue? They have apnea issue too?
So that's an interesting question. And, I'm not an expert in airway. Jeff Rouse certainly is the person in our faculty who has the most experience with airway. And pretty much every seminar I've ever done with Jeff, that question gets asked. And I can tell you that Jeff's position is, if you're talking about positioning the mandible back 1 or 2 millimeters, his belief is that probably doesn't make a difference. If you were talking more than that, potentially, there is an interesting article from 2004, Gagnon published, using full arch appliances in a seated condylar position on patients who had breathing disorders. And his conclusions were that half of the people who were built with an appliance into that seated position, half of them had increased snoring. But what he doesn't mention is, in fact, there were other people that actually did better in that position. Their breathing was better with the appliance in that position. So I would say you have to be really careful about saying things like, well, if you put people in CR that can't breathe, you're going to disrupt their airway. And maybe somebody with a really big shift, but I think in most people, that's probably not accurate.
Can I am I allowed to add a little thing? Because what I think of always in addition to that is that very often what you're doing, if you're restoring someone, is also opening their vertical dimension, which actually gave them more room for a tongue.
Right.
And in hindsight, we've seen a number of patients who did really well, who we probably thought there might have been a breathing issue. Is that fair to say?
And I think the other thing just to add to that is, traditionally we've thought that when we do occlusal appliances, the reason they work is because we're changing people's bites. It may very well be that oftentimes with occlusal appliances, the reason they work is they're actually opening the bite and making more room for the tongue, and the person can breathe better and they feel better. So it's just not nearly as clean and simple as we would have loved it to have been. Back in the 70s, it was clean and simple, just not correct.
Following up your answer about using the leaf gauge or Lucia jig to record, how do you record CR when anterior teeth are missing?
There's a couple of different things you can do. The most common thing for me to do is to typically take some kind of, like, in the old days it was triad, and actually make a little bridge out of triad across to the adjacent teeth, light cure it, and then you can use a Lucia jig against that or a leaf gauge against that. If you're missing anterior teeth, manipulation is one solution to that. But also, if the patient does have some anterior tooth replacement, which I'm assuming they would, you can certainly, if they have a partial, for example, you can certainly use their partial. And if you're talking a restorative case, then you're going to have provisionals that go across the anterior. So you could put your provisional on the anterior, leave the posterior preps exposed, and use your leaf gauge against the provisional there. In other words, make something to replace the missing anterior teeth to allow you to do the recording.
Is there any downfall to neurotoxin treatment of the masseters and temporalis in these bruxism cases when muscles seem like they always win?
You know, I haven't done a massive search on Botox, but I've done a reason. I have patients in practice historically. I can think of about 4 who would go, I didn't do it, but they would go get Botox into their masseters because they were just chronic clenchers and grinders. And the literature does say that it is very effective at helping facial pain. It also does make the muscle smaller. And so you would make the assumption if the muscle's smaller and if they're not clenching and grinding, then yeah, you're helping the teeth as well. So are there negatives? I don't know of any, but as I said, the literature does say that it's an effective treatment.
We have time for one more, and this is an interesting one to end on, I think. What are your thoughts on using the TENS unit to record central relation?
You know, the myomonitor was invented in Seattle in 1968. I'm from Seattle. Barney Jenkelson, when I was a grad student, used to come and demonstrate it to us. And monitor is another way of positioning the mandible. And I think if you really look at it, there are a lot of people that use a myomonitor and they use it very effectively. So I think for us to say, well, no, you have to use CR, that's not true. We know people don't have to use CR. And to say that the myomonitor doesn't work isn't true either. It does work. I think there are extremes. There are cases where I've seen patients come in where the patient was built way down and forward based on using it. And, you know, to me, that doesn't make logical sense to me. But I think a good friend of mine, a periodontist named Jack Ramin, his grad thesis, his master's thesis, was on the repeatability of a myomonitor. And he actually showed that, in fact, it is repeatable within one appointment. So, yeah, it's not something I use. I'm certainly familiar with it, but it's another way of getting a position to have a repeatable intercostal position.
I wish we had one of the most fun things about doing anything around occlusion is that it always stimulates lots and lots of questions. I would offer this. I teach in our workshop, the occlusion and advanced occlusion workshops, one with Darren Deester and one with Jim McKee. You can email me at Spear with, these are some wonderful questions up here. I wish we had time to just stay here and do them, but we don't.
I was going to say,
please feel free to email me at Spear Education and I can connect with you.
Yeah. And
with that,
yeah, there's a tremendous amount of occlusion content online that there's no way we could put into 15 minutes. So I would encourage you, if you're interested in pursuing the different disciplines and seminars we have, that you consider touching base with one of our folks to give you a taste of what the online education looks like in terms of the different topics. I know this webinar is going to be on there, but this webinar really is just bits and pieces of a whole bunch of other content that was taken from. So I would encourage you to investigate that. And, you know, thanks very much again for joining the webinar. And I hope you found it interesting and enjoyable. And I hope someday I get to see you in Scottsdale. Heck, I hope one day we're all back in Scottsdale in person. So with that, Gary, any last comments?
No, thank you, Frank. It's always fun to be with you. And there's nobody who explains things better. Thanks for being with us. Thanks, everybody.
Bye, everybody.